Good morning, and welcome to day 3 of ENDO 2022. My name is Jenny Glenn Gingery. I'm the Director of Communications and Media Relations for the Endocrine Society. Today's ENDO 2022 news conference will focus on emerging research in reproductive health, and we have a really fantastic panel for you today. Over the next 30 minutes or so, each of our speakers is going to present their findings, and then we'll end with a Q&A session. Please note this news conference is being broadcast live via the web, and we have a number of journalists online with us. Because we're broadcasting live on the web, it's quite important that all the remarks are made into a microphone so that those who are joining us virtually can hear as well as those in the room. For those of you who are online, please feel free to type your questions into the chat window as we go along, and then we will answer those in the question and answer portion. So I'd like to invite our first presenter, Dr. Jerilynn Pryor, Professor of Endocrinology at the University of British Columbia in Vancouver, Canada, to the podium.
So, I'm delighted to be here and very pleased to be able to present to you some really quite amazing and rather serendipitous data. Basically, before I get started, I have no conflicts of interest, and I'm grateful to normally live and work on the unceded territories of the Coast Salish people in Canada, and today to be talking to you from Muskogee and Cherokee lands. So the question that this research answers is, does the pandemic alter menstrual cycles, ovulation, or both? We'll come back to that. So this research is two similar cohort studies over a single menstrual cycle that occur in the far southwest corner of Canada in Metro Vancouver area. And I'm talking to you about two cohort studies that basically had the same design, conducted more than a decade apart. And it was kind of, one of those things that serendipity, really, that the study I'm presenting today started recruiting just before the lockdown in March of 2020. We were able eventually to recruit 125 women, and we can compare those with the study we did a decade earlier that had 301 women. It was, as I said, a single menstrual cycle study. Participants were eligible if they were young women, 19 to 35, with about month apart menstrual cycles and were not on hormonal birth control. We used the same recruitment methods, the same catchment area, an epidemiologic multidimensional questionnaire, and every woman kept a daily diary in which they recorded semi-quantitatively their ordinary experiences: flow, cramps, headaches, sleep problems, interest in sex, feeling of self-worth, things like that. So the way in which we documented ovulation was slightly different. During the pandemic study, we used quantitative basal temperature. You're probably familiar with basal body temperature, which is, usually asking a woman to plot her temperature from the first thing in the morning, and then eyeballing it and deciding, oh, it goes up here, so this must be where ovulation occurs. But this is different in that it is using the first morning temperature, but women recorded on a list, and we use a least mean squares method for evaluating it, which we validated against both the serial LH peak levels and also in a blinded study against urinary pregnadiol, which is a common method. And that was the method that was used in MOS, the original MOS study. So we hypothesized that during the pandemic, women would record in their diary increased sleep problems, feeling frustrated, increased feelings of anxiety and depression, And also there's a section there for recording outside stresses. So women could indicate whether it was a difficult day or not. And that was our hypothesis, and since the diary is the same in both, we could directly test that hypothesis. So what did we find? First of all, participants were the same age, about 29 years of age, same body mass index, 24.3, surprisingly, thankfully actually. Similar living situations, a similar proportion that were students living alone or the similar proportion living with other adults. The only difference there was there were none during the pandemic who were single parent families, which is interesting. They differed slightly in ethnicity, so we had slightly fewer white women and more Asian and other ethnicities, which reflects actually better the Vancouver census data now. And there were a higher proportion who were nulliparous. Actually, 92% of the pandemic cohort was nulliparous and had never had children. So we found previously in the original cohort that 90% of the cycles were normal in length, 21 to 35 days, and 90% had normally ovulatory cycles. So that was our baseline, that was our control. What we found during the pandemic was a similar proportion of normal length cycles, 91%, no short cycles, and 9% that were longer than normal, and 37% normal ovulation. In other words, 63% of the cohort either had short luteal phase cycles or anovulation, which is remarkable, unbelievable actually. So in asking, using our data and the comparison between the two, how do we explain these ovulatory disturbances? We looked at all of the collected exercise, sociodemographic, reproductive variables, age at menarche, things like that, and found that none of them explained the difference in ovulation between the two cohorts. However, we could examine the diary data. And some of you may be familiar with this. You use something that's called principal components analysis, which basically puts all the variables into a big bin and spins them around and then comes out with ones that are related to each other in various factors. And we found 5 factors in the original Moss study. And when we compared, especially the first factor, which relates to negative mood, we found that increased frustration, anxiety, depression, sleep problems, headache, and outside stresses were all significantly increased during the pandemic. So in summary, basically we found that menstrual cycle lengths did not differ, and that abnormal long cycles were not more frequent, as one would expect, but that there was a much higher prevalence of silent or subclinical ovulatory disturbances, and that these were related to the increased stresses that women recorded in their diaries, and increased anxiety, frustration, and perceived outside stresses. So basically, to translate that into hormones, it means that the estrogen levels were presumably close to normal, maybe 15% lower, perhaps, that's what we found previously, but that progesterone levels were remarkably decreased. So what are the implications of this? Well, one of the implications I'm sure you all have heard of and probably reported on, the unexpected early bleeding that started occurring in young women when they had their first vaccination. And these results explain that in that when there's not a ovulatory cycle, the endometrium is less stable than when progesterone is there. Therefore, it's more likely under adrenergic or adrenal stresses to show early bleeding. Another interesting observation is that the cramp pain was statistically increased in the women with ovulatory disturbances during the pandemic. And that is a new observation, because previously we've always thought that you needed to ovulate in order to have cramps even. The other is that we believe in this quantitative basal temperature method because it has been shown over and over again to relate to biological variables such as the rate of bone change. And it explained 20% of the bone loss that we showed in an original study we did that was published in 1990 in the New England Journal. We also understand that if this kind of subclinical ovulatory disturbances continue, in other words, if a proportion greater than 30, say, of all cycles have this disturbance, that women are at increased risk for osteoporosis, for early heart attack, breast and endometrial cancers. These are data that are indicated by the literature. Obviously, they need more data. So therefore, we need to know that the women in this cohort or women in a new cohort have recovered from ovulatory disturbances following the pandemic. So thank you very much, and I'm happy to answer questions when it's time for that.
Thank you, Dr. Pryor. I'd now like to welcome our next speaker, Dr. Amanda Schwartz, Reproductive and Endocrinology and Infertility Fellow at the University of Michigan in Ann Arbor.
Good morning, and thank you for the opportunity to present today. Like I said, my name's Amanda Schwartz, and I'll be presenting on my clinical research project, which is looking at the impact of testosterone treatment on IVF in a mouse model for gender-affirming testosterone care. And just a little bit of background, looking at the population that we're discussing. So it's very hard to estimate what the overall quantity of transgender and gender diverse individuals are, because oftentimes it's not included. Gender identity is not always included in all of our survey studies, or there can be heterogeneity in those studies. But using a conservative estimate, about 0.5% of the US population, it extrapolates to 1.4 million individuals in the United States. These are looking at adults only, and 25 million worldwide. And I think whenever we discuss gender affirming care, it's important to talk about the fact that a gender transition is a very personal decision, and that individuals can elect to pursue a gender transition in a variety of ways. And one option is that that transition may include gender affirming care. And in our study, we're focusing on masculinizing care, which is centered around testosterone. Traditionally, that was via IM injection, but now there's also options for sub-Q or transdermal. There is consensus among many of the major medical societies, including Endocrine Society, WPATH, and ASRM, that individuals should receive fertility preservation counseling prior to initiation of gender-affirming treatments. The challenge here, though, is that there's just not a lot of evidence on which to counsel these individuals. So there is a pretty recent prospective study out of Europe looking at amenorrhea in trans men that are initiating testosterone. And the majority were amenorrheic by 3 months, and then 91% by 6 months. And there's also some uncertain impact with regards to ovarian reserve. There's 2 big studies in this space that have conflicting findings, one of them showing no impact on ovarian reserve, and the other one showing a decrease in AMH. And unfortunately, both studies involve hormones other than testosterone, including GnRH analogs and progesterone, so it's hard to kind of get a clear picture. And when we look at histology, unfortunately, there's similar blurriness of sort of what's happening. Many of the studies in histology from trans men on many months of testosterone show persistent ovarian function without significant changes in follicle number and distribution. And that's also what we found in the validation of our mouse model. But then there's also some studies, a lot of the more historic studies, but still some recently, that show a trend towards a more PCO morphology or a trend towards atrophic changes. So while there's certainly no really ability to make conclusive evidence, there is some support for a potential detrimental impact of testosterone on oocyte function and fertility potential.
I'm just going to raise this a little.
Oh, thank you. Unfortunately, when we look at testosterone IVF outcomes, our data is even more limited, which I think can be shown by the size of this tiny table here. But there are 3 case series in the last couple of years that have looked at testosterone used as gender-affirming care and IVF. And 2 of the studies showed that there was no difference in retrieved oocytes between testosterone-treated and non-testosterone-treated individuals. But then one of the studies did show that trans men that had been on T in the past had fewer oocytes as compared to those that had not been on T. And then just a couple months ago out of UCSF, we found the first case study of trans men undergoing IVF while actually staying on testosterone. Importantly, in the other 3, the recommendation was to discontinue testosterone before the stim, as opposed to the case study where both of those individuals stayed on testosterone during stim. And it showed that it was feasible with 30 and 9 M2s retrieved respectively. When we look at this overall, there really are not any standard practice guidelines because of how limited the evidence is. But the qualitative studies show us that when individuals are asked to discontinue testosterone, that can be very dysphoric for them, and one of the most dysphoric aspects of undergoing IVF, particularly when menses resume. And so the research question that our lab is trying to answer using our mouse model is, how does testosterone exposure impact IVF outcomes? And if there is a negative impact, does it show any reversibility with cessation? So in order to answer this question, we set up 4 treatment arms. So we have implants in black 6 mice of silastic tubing that were either sham implants of ethanol alone, or they were testosterone and thanate dissolved in ethanol. And so our immediate groups, they received the implant at 10 weeks of age, were implanted for 12 weeks, and then underwent IVF stim with implants in place. And then our cessation groups were explanted after the 12 weeks of treatment, had a 10-day washout period, and then underwent IVF at that time. A little bit more about our study design here. So we used a validated hyperstimulation protocol shown here on the left, and our oocytes were fertilized using a hybrid strain that is meant to optimize fertilization success. And then what we did was we cultured to the 2-cell embryo stage and then transferred them in a 1-to-1 ratio into pseudopregnant, and to a female pseudopregnant mouse colony. And our study was powered to detect a 25% difference in 2-cell embryos. This first slide here is just showing the overall feasibility of our model. And so on the left, we see, as expected, that our testosterone-treated mice cease cycling within the first week of implantation, while our control mice continue to cycle. And then on the right, we have our hormone levels. And so again, showing validation here is that our testosterone treatment groups, the red and the purple, have testosterone levels that are significantly elevated compared to the controls throughout the duration of the study, with the exception being that our T washout does have a testosterone level that comes back to control after being explanted. And then we have our terminal hormones shown here, which were obtained at the time of the oocyte retrieval. And so there we did see a decrease in AMH in our immediate treatment groups, with the testosterone-treated mice having a lower AMH compared to controls. And this was no longer present in our cessation groups, where we see evidence of potential AMH recovery. And then no significant difference in the estradiol or progesterone levels, and then the terminal hormones are as expected, with the immediate group having high T and the cessation group having T that is comparable with controls. And then this slide here really shows what our IVF outcomes were. And so in our immediate group, we see that the mice that were receiving active testosterone have a lower yield of total and mature oocytes, which then correlates to a lower number of 2-cell embryos. And in the cessation group, there's evidence of recovery here after the testosterone implants were removed because the control and T groups no longer have significant difference in any of those IVF outcomes. We looked also at maturity and fertilization rate as a way to try to estimate if there was an impact on oocyte quality, which of course is very challenging to study. But we found that there was no difference in maturity or fertilization between control and testosterone treated mice for either the immediate or cessation groups. And then I just included some pictures here. The top row is showing our M2s, and then underneath that you see the 2-cell embryo stage for each of the treatment arms. And then finally, we have our embryo transfer outcomes. So we did see an increased probability of achieving a live birth for the control group as compared to the testosterone group that underwent IVF with their implants in place. And our study, though, we see a trend towards a higher number of pups and a higher live birth rate in the controls compared to the testosterone treated. Those did not achieve statistical significance. So when we look at our results kind of as a whole, we do see a negative impact of testosterone on IVF outcomes for those that are receiving active testosterone treatment, and that was represented by a lower yield of oocytes, which then correlated to a lower number of 2-cell embryos and a lower probability of achieving a live birth from a single stimulated mouse. What I think is more promising, though, is that we find that these outcomes are improved following testosterone cessation, with no longer seeing a decrease in the oocyte yield from IVF. So overall, our study supports a potential reversibility of an impact of testosterone on reproductive potential. And certainly, many further studies are needed to determine the impact of testosterone on further embryo development, as well as on the F1 offspring, which are the studies that our lab is currently conducting this summer. And then when we think about our original research question of really how are we going to counsel individuals on gender-affirming care as they weigh the challenges of potential dysphoria from testosterone discontinuation versus potential for having a lower IVF yield, certainly we need more research, both at the basic level and then I think kind of multi-center human studies as well before we can really answer that question, but this is sort of a first step in that direction. Thank you for your time, and I'm happy to answer questions.
Thank you so much, Dr. Schwartz. Next, we'll have Dr. Genevieve Neal-Perry, Distinguished Professor and Chair of Obstetrics and Gynecology at the University of North Carolina School of Medicine in Chapel Hill.
Good morning, and thanks for being here. And I'm going to talk about a topic that's near and dear to my heart, and that's menopause and management of menopause. Okay. A few disclosures. I myself am on the scientific advisory board for Astellas and have contributed to the design as well as interpretation of data. So vasomotor symptoms are common in menopause. In fact, they're one of the most common causes for a woman to present to her doctor for care during menopausal and postmenopausal phases of their lives. Approximately 34 to 46% of women who have vasomotor symptoms describe them as being moderate to severe, and that they interfere significantly in their daily life activities, in addition to having impacts on their ability to function. Vasomotor symptoms are typically treated with gonadal-steroids or estrogen, and that has been the kind of gold standard for management. But with the advent of WHI, this has caused quite a few women to consider whether hormone replacement was optimal for them. And then, in addition, there are other individuals who have hormone-responsive cancers, as well as other disorders that may prohibit them from using the gold standard, which is estradiol or estrogen. So instead, they've used alternative non-hormonal treatments such as SSRIs, clonidine, gabapentin, and some herbal remedies that have really barely achieved more than placebo in some instances and often have lots of side effects. So fezolinetant is a non-hormonal selective neurokinin 3 receptor antagonist. and it has been shown to moderate the activity of neurons that we now know are located in the hypothalamus and that actually contribute to the development of hot flashes. And so the goal of the study is to understand whether fezolinetant might actually prevent hot flashes. So just to step back a little bit in terms of the mechanism of hot flashes, over the last 10 years, we've actually learned a lot, and I would say really over the last 5 years, about the cause of hot flashes. And what we know is that there are these neurons called KNDy neurons, KNDy neurons. They express kisspeptin, neurokinin, and dynorphin. And in response to estrogen, they are very quiet and they're not very active. They will actually project to neurons in the thermoregulatory region of the hypothalamus, of the medial preoptic area, and in the presence of estrogen, they're just kind of projecting kind of brief interactions with these neurons. However, in the menopause and perimenopausal period, when you have less estrogen around, these neurons become hyperactive, and they release these neurokinins as well as dynorphin and kisspeptin, but in particular, neurokinin will impact these neurons located in the thermoregulatory region of the brain and trigger what we know and feel as a hot flash. And so what fezolinetant does is it interferes with the receptor for the neurokinin peptide, and so that it dampens that activity of the neuron, thereby decreasing hot flashes. And that's what our proposed mechanism is. So the hypothesis is will fezolinetant reduce the severity and frequency of moderate to severe vasomotor symptoms when compared to placebo? And this was a double-blind, placebo-controlled study. It was a multi-center phase 3 study of 120 centers across the United States, Canada, Latvia, Spain, Czech, and the U.S. And again, the primary goal was to determine the efficacy of fezolinetant compared to placebo in terms of the impact on frequency and severity of moderate to severe vasomotor symptoms associated with the menopause. We had several endpoints. The co-primary efficacy points was mean change in frequency and severity of moderate to severe vasomotor symptoms, and that's at baseline, from baseline to 4 weeks and then 12 weeks. And the way that this was assessed was that we had patients actually have an electronic diary, and they provided feedback about the severity as well as the frequency of hot flashes. And then our secondary efficacy endpoint was a mean change in frequency and severity to moderate and severe vasomotor symptoms from baseline over the entire 12 weeks. In addition to this, we also reported mean changes in patient-reported outcome measurements, information system sleep disturbances, and particularly wanting to understand whether there was also an improvement in sleep. We do know that women who have vasomotor symptoms often have sleep dysfunction that we do believe is in part related to the severity and frequency of hot flashes. So this is the study design here. We had patients who were screened and who were otherwise healthy with no other endocrine disorders that might impact hot flashes. And then they were randomized into 1-to-1, so placebo, a 30 milligram, 45 milligram dose. And we evaluated them at 4 weeks and then at 12 weeks. And at 12 weeks, the placebo group was then re-randomized to either 30 or 45 milligrams of fezolinetant, and then we followed them out to 52 weeks in terms of that was the last visit treatment, and then we assessed what their outcomes were. And in terms of the demographic data, and this is actually something that's really important because a lot of studies that were done looking at vasomotor symptoms often did not include a large cohort of women of color who actually have a large burden of hot flashes. And this study did. It was about 20% of the study group. The vast majority were Caucasian. We had a smaller group of Asians, Native Americans, Alaska Natives. We had about a 20% group of individuals who identified as Hispanic or Latina. There was no significant difference in age, BMI. Really important to also note that we included a obese group of women, because often these women are excluded in studies that are looking at the impact of treatment on hot flashes. And so this is an important group to treat because they also have a significant burden of hot flashes. The time since the onset of hot flashes was not significantly different amongst the groups, and we also included individuals who had hysterectomies. What this first slide shows, I'm going to orientate you here, the y-axis is daily mean frequency or severity, the x-axis is time. The gray, and this will be true throughout the additional reports, is that gray is placebo, the green is 30 milligram, the blue is the 45 milligram. And what you see with the treatment of fezolinetant or placebo, you do see some response to placebo. This is standard. This is what you see in most studies. But significantly see a significant reduction in the frequency of hot flashes in individuals who are on either 30 or 45 milligrams of fezolinetant. And they continue to decrease over time to the 12-week point. And this is a sustained reduction. In terms of the severity, I want to give you the daily severity in terms of how it's assessed. It's a scale of 1 to 3, okay? And so what people report is whether the severity is better or worse. And what we see, which I know it's a little hard to tell because the numbers look so close, is that with the fezolinetant, we see that there's a significant reduction in the severity of hot flashes as reported by the individuals who are affected. When we then looked at the groups over the 52-week study, you see that the individuals who were actually crossed over to treatment, they actually saw a significant reduction in their hot flashes, and they look very much like the individuals who were randomized at the beginning of the study, and this continued out to 52 weeks. And similarly, this was observed with the frequency of hot flashes. In terms of the sleep, sleep duration or sleep maintained over the duration of the study, we found that with the higher dose in the 12-week period, that the higher dose of fezolinetant provided an improvement in the sleep in terms of sleep symptoms. And then this continued out to 52 weeks. We could not do statistical analysis because we did not have a placebo group to follow out to 52 weeks. But I can tell you at 12 weeks we saw improvement in sleep, and that it continued out to 52 weeks, and that for those who were or in the crossover, we also saw a benefit for those individuals. So treatment emergent adverse events are really important because some of the other drugs that are like this category had significant side effects that required them pulling it off the market. The most common side effect associated with fezolinetant was actually headaches. There were no significant side effects that required people to pull out of the study. We did have one death. That death was related to a car accident. But overall, there were very few side effects associated with the drug, and it was tolerated well for patients who were actually using it. The COVID was obviously a common reported adverse event, but that was also because the study was done during the COVID pandemic. So in conclusion, fezolinetant, both the 30 as well as 45 milligram doses were really efficacious in terms of improving the frequency and severity of hot flashes. It is a novel non-hormonal treatment that women who either cannot take hormones or who have for some reason selected not to do so, who may now have an opportunity to have treatment for their bothersome symptoms. So I am also thankful for your attention and happy to take questions. Thank you.
Thank you, Dr. Neal-Perry. I'd now like to welcome Dr. Ricardo Aziz, professor at both the University of Alabama at Birmingham as well as SUNY Albany.
Good morning, everybody. Fairly quick. We study the economic impact of mental health disorders associated with polycystic ovary syndrome. few disclosures, nothing important in this regard. I think it's first important to understand that polycystic ovary syndrome is the single most common endocrine disorder of women of reproductive age. This is an early study that we did, and in fact, the first study worldwide that was done looking at the prevalence using very, very severe and uniform criteria. At least 6 to 7% of all women are affected with polycystic ovary syndrome, and today we know that it's closer to 10%, so 1 in 10 women are affected with polycystic ovary syndrome. Now, polycystic ovary syndrome has a tremendous impact on the women that it affects. It impacts fertility, risk of diabetes, risk of heart disease, risk of stroke, quality of life, and so on. But it is also impacts on the prevalence of mental health disorders. It's very clear that women with polycystic ovary syndrome have a much higher rate of mental health disorders than the general population. There's a number of factors that depress the quality of life in these women. Hirsutism, right? Being bearded, if you would, is really something that impacts these women. You can imagine that a 16-year-old who has to shave before she can go out on a date is something that is not conducive to high quality of life. Being overweight, which tends to be somewhat more common in polycystic ovary syndrome patients, tends to be a problem, and of course infertility and so on. Lots of factors that depress the quality of life of this very, very common disorder. Now, we did a study a number of years ago. We've actually done a series of studies looking at the economic burden of polycystic ovary syndrome. Now, we're only looking at the direct medical costs of economic burden. There are other costs that we're studying currently, costs like indirect costs related to work productivity, intangible costs related to quality of life. Those are harder to assess. But right now, we've only looked, if you would, at the medically related economic burden. And this was a study that was published actually in JCNM just a couple of months ago, looking at this. And we noted that the impact of the economic burden of polycystic ovary syndrome, when you include the cost of its diagnosis and the cost of related complications like pregnancy-related complications, as well as long-term morbidities like diabetes and stroke, amounted about $8 billion yearly in the United States. And this is a very conservative estimate because, again, we use the narrowest of definitions for polycystic ovary syndrome. Now, we were interested also in the economic impact of mental health disorders and polycystic ovary syndrome. And in our study, we did a large meta-analysis of literature, and we observed that the odds of anxiety were 77% higher in PCOS. The odds of eating disorders were 53% higher, and the odds of depression were more than double in polycystic ovary syndrome. And this is related to the general population. Of course, the general population does have anxiety, depression, and eating disorders. In our estimate, the additional direct healthcare costs associated with mental health disorders and PCOS were estimated to be almost $3 billion yearly just for depression, about $2.2 billion yearly for anxiety, and about over $500 million yearly for eating disorders. Now, the challenge is that this adds a huge amount of economic burden to patients with polycystic ovary syndrome, right? This is about mental health disorders alone account for about $6 billion, and that's not even including postpartum depression, which is something we are studying. You add that to the earlier study of $8 billion, we're talking now about $14 billion of just direct medical care without actually the longer-term kind of risk, right? These women tend to be younger, and so we don't know what happens with them over time. But there is a significant disconnect between this study, right, these mental health impacts, and really what health policy is. This is another study we did a few years ago, also published in JCNM, looking at research in polycystic ovary syndrome. And I don't have a way to point, or do I? Yes, maybe I do. All right, I can do that. All right, and what you can see is if you take disorders that are similar, morbidity, in this case rheumatoid arthritis, tuberculosis, and lupus, PCOS is significantly lower in funding, and it's in fact significantly lower in funding relative to other reproductive disorders like endometriosis and fibroids. So what happens is that polycystic ovary syndrome tends to be underfunded by the agencies, mainly because it's a disorder of women, so people don't really particularly care, unfortunately, and it's the way policy works. But more importantly, it's such a pleomorphic disorder. It affects the heart, it affects metabolism, it affects the mind, it affects fertility, that at the end of the day, the agencies that are in charge of funding just simply do not fund. So this is something that there's a significant disconnect between this economic burden. So why is PCOS and male hormone excess in women such a hidden and ignored epidemic? Lots of stories, lots of reasons, but you should know at least the top ones. One, it's its history. You know, we always talk about bearded women in a sort of a funny way. We've stigmatized these women over years, and in fact, they all suffer, the vast majority of polycystic ovary syndrome. You know, we have this misguided but common view that it's a cosmetic disorder, that, you know, God made you that way, and so that's unfortunate, and it's not a disease at all. There's a lot of shame of affected women, so there's a large number of women who are affected who simply will not talk about it. You know, they will not actually speak about this because they feel ashamed. There is a misguided impression by patients and doctors alike that PCOS is solely a reproductive disorder and not a vascular metabolic disorder, which it is. And again, the heterogeneity of the syndrome in the past has sort of caused people to be confused. And finally, to be fair, the name, right? Polycystic ovary syndrome makes you think of ovaries, make you think of polycystic, but that's just a historical name. That was the reason that in 1935, the best way you had of diagnosing these patients was to take out their ovaries by surgery. We don't do that anymore. But unfortunately, the name continues to affirm the biases and the stigma that these women have. So in the end, about 1 in 10 to 1 in 7 women in the United States suffer from polycystic ovary syndrome. The medical and economic impact is huge, and it's growing as we understand it better. It affects many different areas, not just quality of life, not just fertility, but also metabolic risk, heart disease risk, and stroke. And there's a big disconnect between the disorder itself and what we prioritize as funding in the United States. Thank you very much, and we're happy to answer any questions. That's it. That's the summary.
Thank you, Dr. Aziz. I'd now like to begin the question and answer session. So we'll go ahead and have Colleen has the microphone if you're in the room and would like to ask a question, and we'll also be reading questions from the chat.
Hi, Miriam Tucker with Medscape. Dr. Pryor, I think you said that the second cohort, you started it right at the beginning of lockdown in early 2020. But are you attributing the findings about ovulation to the anxiety and the emotional aspects of it, or is it possibly the virus itself was playing a role?
Okay, first of all, we did not include women who were sick with COVID. And obviously early on, we didn't see any long COVID either. So as far as I'm aware, we had no one during the study who was sick with COVID. So it was the changes in employment and going to work and caring for kids and caring for elders and worry about illness in somebody you loved, probably, that was related.
I would wonder what would happen if you did the study right now. What do you think?
I don't know. We're still in a stressful time with inflation and not complete recovery, so probably the issue is still very present.
I have a question for Dr. Neal-Perry, and this is from Ted Bosworth at Medscape. You mentioned the high inclusion of several specific subgroups, African American, high BMI. Did you look at relative responses in these groups? You said that there were adverse events associated with previous drugs in this class. What were they, and any speculation about why fezolinetant did not share these adverse events? If the drug is approved, would you recommend in any symptomatic women?
We can go back and read part by part if that's
Yeah,
helpful.
that'll be helpful. I won't remember. So the first question was, I forgot, I should have wrote it down. What was the first question? Subgroups, thank
Yes.
you. So The question was whether we did we drill down to try to assess the impact, or whether you saw a improved impact in African American or women who are obese, and we haven't done that yet, and that is part of our plan. We do know from studies of women across the nation that there is a higher burden of hot flashes in obese women as well as in African American women, and that they're less likely to respond to some of the other non-hormonal therapies. We are enthusiastic because we did see a significant difference, so we think we will see a difference in those subgroups, but we haven't done that analysis yet, and that is planned. And then the next question.
You said that there were adverse events associated with previous drugs in this class.
Yeah.
What were they, and any speculation about why this does not share these adverse events?
Yeah, so the previous drugs in this category, norokinin receptor antagonists, the previous drug was it wasn't a selective norokinin 3 receptor antagonist, it was a mixed, it was 1 and 3, and those receptors are actually located in our liver, and so in those studies they actually saw increased levels of liver enzymes, and there was concern about hepatotoxicity. And with fezolinetant, we saw a few cases of elevated of liver enzymes, but there were a few cases, and most of the women actually recovered during the treatment, so that we did not have to discontinue treatment. In those women, we're not sure whether there may have been some baseline fatty liver disease, and so that is one of the things that we're also thinking about, and that would be another reason to look at some of the differences between our obese and non-obese women, because you're more likely to have fatty liver disease in obese women.
And then the last part of the question, if the drug is approved, would you recommend it in any symptomatic women?
So if the drug is approved, certainly, I'm excited about it because it's really, there hasn't been a lot of focus, just like PCOS, a lot of focus on hot flashes is something that women are just expected to live through. And the management in terms of really effective opportunities and therapies have not really been there for, one, lack of funding, similar to PCOS, two, not understanding the mechanism by which hot flashes occur. So the understanding the mechanism really provided a springboard to a drug discovery. And so in that context, I would say yes, because we do know that hot flashes are very disruptive. In terms of cost to manage it, well over $3 billion to do so. So in individuals who have hot flashes, certainly would say yes. For individuals who have hormone-responsive cancer, who have blood clotting disorders where they can't take estrogen, this is a boon because they really haven't had other treatment options that are highly effective without significant side effects.
Thank you so much. I have a question here for Dr. Schwartz. What might these findings mean for women with PCOS?
Yeah, that's a great question. Thank you. I think that part of the motivation of Dr. Moravec in designing this model is that the idea that gender-affirming care is equivalent to PCOS and that we could just be using PCOS models, I think misses out on the fact that there's potential prenatal exposures or multifactorial components of PCOS that make it really different from gender-affirming care. In our study results, we found a lower oocyte yield for the individuals that were on active testosterone, which really would be less consistent with PCOS. And we also saw a lower AMH, which also would be, obviously not every PCOS woman will respond exactly the same, but the general trend in IVF is that you tend to get really high yields and you have a trend towards higher AMH. And so I think it's challenging to try to take the effect of androgens only that we're seeing in our model and trying to extrapolate that to the PCO population. So I think it would be really hard to parallel those findings from this model alone.
Thank you so much. Anyone else have a question in the room? Sure.
Mike Menasher from Endocrine today. This is for Dr. Pryor. How can these findings be used moving forward, both specifically with future pandemics, or even as you said, like tough economic times, that sort of thing? And can these findings be translated on an individual basis, caring for individual women who may be going through stressful times in their own lives?
Very good question. The translation is, for me, is quite practical and obvious, and that is that we have only looked at cycle length, and we haven't looked at ovulation characteristics previously, and I think we need to do that. The implications are huge for women in terms of symptoms, but also in terms of fertility, because a short luteal phase or an anovulatory cycle is not a good fertile cycle. The effects are extremely applicable to individual women. And I should also say that they're applicable to men as well. I remember as a clinician seeing a very, very stressed young man who was working on his PhD and having trouble writing his thesis and came to me for infertility. And I said, you know, when you get this thesis done, you're going to be fine. In other words, these are reversible. These are health protecting strategies that are fundamental to the biology of people and of animals to prevent pregnancy at a time when there's just too much duress or not enough food or, you know, threats to physical life, et cetera. So they're, and it's a graded response. It's a carefully graded response. So we were surprised in previous prospective data over a full year, the highest prevalence was of short luteal phase, like 25% of the abnormal cycles were short luteal, not enough progesterone timing. But in this study, there were equal proportion of short luteal and anovulatory, no egg release at all. So it's a graded response depending on the individual's personal, subconscious, really, brain perception of the stress that that person's under.
Hi, I'm Lisa Nengolan from Medscape. I have a question, perhaps for Dr. Schwartz, but I think maybe others might have something to say regarding transgender men who decide that they do want to have children, or even earlier on with regard to fertility preservation. Presumably the ideal would be egg freezing, but we know that's quite expensive, etc. Can these individuals really conceive and carry children while still taking testosterone? And other questions that might arise from your answers. Sorry.
That's a big question, certainly beyond the scope of our mouse model. Like, certainly in doing kind of reviews of the literature, there's been case reports of individuals that have gotten pregnant while on testosterone because the suppression of ovulation is not complete, even for individuals that are amenorrheic. And they haven't found significant impacts on the offspring or like an increased risk for preterm delivery in those studies, but they're very, very small.
But do they continue taking the testosterone during the pregnancy?
Okay. No, it's unintentional pregnancies in those. There was a couple of review studies out of California or out of UCSF looking in that space. So, you know, I don't think anyone's recommendation at this point would be to continue testosterone intentionally while pregnancy. Certainly that wouldn't be our group, but I'm not sure what everyone else kind of has on that space.
Testosterone would be considered teratogenic, right, if continued. But there are rodent studies where they have continued with the androgens, or really it's elevated estrogens that can cause some epigenetic changes in that modified brain in terms of reproductive centers of the brain. To your question of whether they can get pregnant, the answer is yes. You know, is it recommended when they're on, you know, when they're taking androgens? No, because of the impact of the androgens on fetal development. If they have a female fetus, they can cause changes to the genitalia so that they have ambiguous genitalia. In terms of egg freezing, you know, when seeing patients, trans men, we often do encourage it, but access to fertility preservation is a problem not just for trans men, but for people who don't have the resources to actually obtain it, and that could be cancer patients with a diagnosis of cancer as well. But you absolutely can, freeze eggs. We don't know what the impact of androgens will be long term on
presumably, if you counsel younger trans men before they start testosterone to freeze eggs, it's not always at the forefront of their mind that they might want to have kids. And
so, interestingly, a lot of times they don't want to talk about that. That is what their focus is their transition. And if funds are rate limiting, they're going to use their funds to assist with the transition. And that is, I don't know what your experiences are, but I find that a lot of trans individuals undergoing the transformation, trans men, that is just, they're not in a mental space to talk about that. And really their goal is to talk about their their transition.
I have to agree with all the comments. We see a fair amount of these patients. The one thing we can do, in effect, an impact on younger individuals as they really are focused on trying to be who they are, is really not to have a hysterectomy and their ovaries removed. That's the single one thing that we can impact on their later fertility. As far as whether you oocyte, freeze oocytes or you don't and so on, I think those are things that unfortunately are always left for later. We don't think there is a permanent damage to the ovaries from the testosterone. Of course, you all know that there are different kinds of testosterones, and so in a pregnancy, some class the placenta, some do not. But the point really is, we don't think there is lasting damage to the oocytes from the testosterone long term. There is lasting damage to the fertility if the ovaries are removed.
And what would be the ideal time to counsel people to, how long do they need to stop taking testosterone before they can try to get pregnant?
I'll give it a try, and you have a study. So, it actually varies. We talk always about the 3-month window. You try to do it a little bit longer, but again, they are also going to suffer the side effects of the withdrawal from the androgens. They are in a social setting where that may not be the right thing. But we usually talk about 3 months. But again, Dr. Schwartz may have a thought.
I would agree. I think certainly in our space with both the REIs and MFMs, the 3 months is generally where the recommendation is based on, and trying to minimize effects, but also minimize the gender dysphoria that would be potentially ensued.
Thank you.
And that 3 months is based on studies where it looking at metabolism and looking at peaks and nadirs of the hormones, but it also would typically say 3 months.
All right, we just have one more question online here. What is the option for syndrome terminology for PCOS? I'm not sure who exactly, that might be Dr. Aziz.
I'm sorry, can you repeat that question?
What is the option for syndrome terminology for PCOS?
I think the question from the person making that question is really, what else could we call polycystic ovary syndrome?
Okay.
And I can tell you that I've funded studies, I've funded conferences on how to figure that out. Other colleagues have done assessment of patients and so on. There's just no good name yet, which is why the name has not yet transitioned. We talk about the metabolic reproductive syndrome as being one. We talk about the hyperandrogenic and ovulatory syndrome as being another. But these are all syndromes, names that actually reflect sort of the features of the disorder. So we are still in the process of trying to figure it out. You don't want to lose the brand of polycystic ovary syndrome, if you would, or PCOS, because people do recognize it, even though, in fact, it is a barrier to many people understanding the broadness of the disorder, the breadth of the disorder. So nothing new that I would suggest today, but there's been a number of attempts to try to find the right name.
Great, thank you so much.
Thank you.
Any other questions?
On
from
that
anyone?
same point,
Oh,
I would
sure.
like to call it anovulatory androgen excess, because that emphasizes the lack of ovulation or the disturbance of progesterone production, which we often ignore.
Yeah, unfortunately, about 20% of patients with polycystic ovary syndrome are actually ovulatory, so they don't. And about 20% actually are non-hyperandrogenic. So we still have a bit of ways to go. So, but thank you very much.
Thank you so much to all of our speakers and the journalists in attendance. It was a really fascinating discussion this morning. As a reminder, recordings of these news conferences will be available on the Society's website as well as our YouTube channel. If you have additional questions or would like to set up an interview with one of our presenters, please contact us at media@endocrine.org. Thank you.